Great. So I see participants are joining. I'd like to welcome everyone to this session, which is titled Practical and Demonstrated Clinical Strategies to Address Viral Load. Good morning, good afternoon, depending on where everyone is. My name is Jason Williams. I'm the Technical Branch Chief within the Supply Chain Division within OHA, predominantly working on technical aspects of products related to ARVs and diagnostics, and most of what I do focuses on lab network efficiencies, procurement strategies, and just broad kind of diagnostic network optimization approaches. This session, though, will focus on IP efforts, the clinical level, to address viral load coverage and suppression issues. Obviously, viral load coverage and suppression is a big measurement of PEPFAR's overall success as part of their programs. This session will focus on some of the pre and post components of the viral load cascade, and presentations will cover sort of workflow dynamics, targeted surge-related activities, and taking a closer look at sample collection and testing methodologies to improve viral load coverage and suppression, particularly at lower age bands for pediatrics, for example. Today, we have 3 presentations from 2 countries, 2 from Malawi and 1 from Lesotho. As folks are aware, Malawi shifted routine viral load testing from every 2 years to annually a few years back. And what that did is that overall kind of reduced their coverage measurements. So we'll focus on some of the efforts that some of these IPs have taken to dramatically increase and align viral load coverage as a measure that PEPFAR reports on. The third will take a look at Lesotho and some of the strategies that were employed to address some of the coverage and suppression related issues on the pediatric side. Each presentation will constitute about 15 minutes of the presentation each, followed by 5-minute Q&A. And then what I'll try and do is do a 5-minute wrap up. Feel free to post in the chat if you have any direct questions for individual speakers. I'll do a brief intro of each speaker and a little bit about each one of their presentations, and then I'll hand it over to the presenters to give their talks. The first presentation will be by Mackenzie Chivuara, who works at Partners in Help. He's been a monitoring and evaluation director there for the past 17 years. And he will be talking specifically around some of the efforts on task shifting, HRH in Malawi. The second presentation will be on Lesotho, and that will be presented by Mosa Lapau Lasoa, who will speak to efforts in the highlands of Lesotho, addressing some of the pediatric challenges they've experienced in the past there. And this will be all under the Baylor Ethics Project. Our third speaker will be Shalon Dunga, also from Malawi, and they will speak to surge-related activities under the Baylor College of Medicine Children's Foundation. So I'd like to welcome each one of our speakers, and hopefully we'll have a good dialogue and some good questions coming following the presentations. I'd like to hand it over to Mackenzie to start the session. And again, he will be speaking particularly around some of the task shifting related activities that Malawi employed specifically to address some of the operational aspects within clinics associated with viral load coverage and suppression in Malawi. So with that, I'd like to hand it over to Mackenzie. And again, if folks have questions, please do post them in the chat, and we'll address some of them following the presentation. So thank you. Over to you, Mackenzie.
Yeah, thanks, Jason. It's quite a privilege for Partners in Hope, as one of the PEPFAR implementing partners in Malawi, to have been selected to share our experiences with others as regards to viral load uptake in Malawi. Next slide. So just a bit of a background to Partners in Hope. So Partners in Hope was established in 2004 and is a local Malawian non-government organization with a Christian background. Partners in Hope also has a high quality medical facility with comprehensive clinical inpatient, outpatient, and diagnostic facilities. We are also supporting the national viral load testing in Malawi, and we are also a molecular lab for viral load testing in Malawi. Again, Partners in Hope is also privileged to be one of the PEPFAR local implementing partners that are implementing PEPFAR funded activities through USAID in collaboration with the University of California, Los Angeles. Currently, Partners in Hope is implementing care and treatment programs in 9 districts, 3 of which are our scale-up districts. In total, we are reaching out to about 123 facilities in the 9 districts. Next slide. So just a bit of also a background to viral load scale up in Malawi. In 2016, Malawi adopted the routine viral load for every 2 years. And during that time, we had 10 molecular laboratories and a total of 16 platforms. And in 2018, to date, the guidelines for viral load testing in Malawi changed from every 2 years to annual viral load. And also the total number of molecular laboratories increased from 10 to 12, and the total platforms from 16 to 23. And we can also see the achievement of viral load testing from 2015 up to 2020. With the effect of COVID also playing its bigger role in terms of target achievement in 2020. Next slide. As I indicated, that Partners in Hope also is a molecular lab, and currently we are supporting about 15% of the total national viral load testing in Malawi. And we can see the cumulative trajectory of the support that Partners in Hope is providing to the national viral load testing in Malawi. Next slide. So coming to the subject matter of achieving increased uptake of viral load monitoring through task shifting to data clocks in Malawi, I just want also to provide a bit of a background to Partners in Hope approach to data management in Malawi. So over time, we have noted that there was need to improve, number one, data quality, but also to support increased PEPFAR data requirements. For us to be able to achieve that, we had recruited and deployed facility-based data clerks. Currently, we have about 202 full-time facility-based data clerks in all the 123 facilities. Their core responsibilities basically is facility-level data management, including EMR data entry, extraction, and also reporting. Now, as a task shifting intervention, in Malawi, we also have quite a big challenge in terms of number of trained providers across the country. As such, this also becomes a challenge as we implement care and treatment programs. But with the deployment of data clerks, we felt there was an opportunity to utilize this lay cadre staff to support increased uptake of viral load monitoring. So we felt of engaging data clerk to support this process through the following processes. So number one, we engage data clerks basically to be reviewing and flagging medical charts for patients that are due for viral load testing. We also developed the standard operating procedure in terms of how data clerks can come in and support this process. But also being an initiative, we had to conduct on-site trainings, provided mentoring and coaching in 2019, March 2019, when we had rolled out this initiative. But also we implemented and evaluated the task shifting strategy between 2019 to 2020, just to see how the results were coming out. Next slide. So just a bit of an explanation in terms of the viral load testing SOP. So number one, we ensured that data clerks basically review MasterCard of clients who are due for the clinic the following day, and basically place a sticker on the MasterCard for clients that are eligible for viral testing. And this basically happened a day before the clinic, so that we prepare clients and all cards are reviewed and MasterCards placed with stickers for those that are due for viral testing. On a clinic day, basically data clerks who are also the who manage the front line direct all the clients with stickers that have been flagged due for viral load to viral load testing room for sample collection. But they also do record all the clients that are due for viral load testing and have been directed for viral load testing. At the end of the day, they also double check in the viral load sample log to see how many of the clients that were directed basically had their samples collected. Let me also mention that apart from data clerks, Partners in Hope has also invested at facility level, placing HIV diagnostic assistants who basically draw samples and record in the viral register, MasterCards and FA passports. In addition to HIV diagnostic assistants, Partners in Hope has also invested in recruiting patient supporters who support in terms of creating demand for viral load services, but also tracing clients that miss their viral load testing at the designated milestone. But they also do work alongside providers at the healthy facilities. Next slide. So this is a demonstration of the intervention that I highlighted about increasing viral load testing uptake. So as we can see from the results, that when we had started the intervention, we almost had 100% increase in viral load testing uptake. With the later impact of reagent stock out and COVID-19 pandemic. But otherwise, we can clearly see the significance and the impact that this task shifting intervention had in terms of overall viral load testing uptake at facility level. Next slide. So as is the case with probably every other initiative, new interventions, we also encountered challenges in the process of implementation at facility level and national level. At facility level, basically we started implementing the initiative without putting a proper SOP to guide the process. So sometimes data clerks would just flag the MasterCard, put a sticker without actually directing clients for viral load testing, with the understanding that the providers would be the one to now direct the clients to do the viral load testing. So what we noted was that eventually most clients were just getting their medication and off the leave for their homes. So we noted that that was a gap. But again, we also experienced conflict of responsibilities between data clerks and HIV diagnostic assistants due to unclear job description. So the initial cadre to be recruited and support HIV interventions in Malawi were the HIV diagnostic assistants. So by the time we were recruiting data clerks, we had overlooked to make it clear in terms of the job description, and so that also created some conflict. Again, data clerks and clinical providers also required additional time and effort to basically orient them, mentor them, and supervise them in the process, just to make sure that they all understood the expectations, but also the implementation of the initiative. At national level, we encountered also quite a number of challenges. Number one, we encountered national stockouts of reagents, viral load equipment breakdown. So even though samples were being collected and transferred to a molecular lab, we encountered also equipment breakdown. The laboratory information management system, which is the system through which viral results are reported, also had challenges in terms of connectivity and also downtime. So all these combined basically prolonged the TAT for viral load testing and result reporting. We cannot conclude without mentioning also the impact of COVID-19 in the whole process. Next slide. So in conclusion, we could easily see that just a simple task shifting initiative utilizing the RECADLA, the data clerks, contributed dramatically in increasing viral load testing in Malawi. The initial challenges occurred at health facility and national level, as I had earlier on highlighted. But also something that is also amazing is that data clerks and other lay health workers also play a very crucial role in supporting other steps along the viral load cascade. In the process, making new viral load results available to clients and providers at the next clinic, but also updating the electronic medical system so that they can also flag in terms of viral load alerts in the system, but also identification of patients with the high viral load results for tracing. Again, these were also some of the experiences that we have noted. Lay cadre staff also can play at facility level. Next slide. So, way forward in terms of additional measures to improve viral load update. Right now, number one, as I've said, when results come, basically we have to enter them into the electronic medical record system currently available in Malawi, and we are also working with the HIS partner to provide mechanisms in the system that they can be flagging clients that are due for viral load. We also initiated a monitoring tool at all health facilities in terms of viral load uptake and tracking clients, as I already had highlighted, where we basically track how many clients that were due for viral load on that particular day and how many clients had their viral load taken. So this monitoring tool is in place at all facilities, and we track this at every other clinic in the 123 facilities that I mentioned. We also initiated making sure that every other health facility has a full-time focal person that basically champions and checking that viral load uptake is happening and is being done well, and making sure to addressing all other facility-based challenges as a result to viral load testing and uptake. Again, there is also a need to intensify monitoring, making sure that we align viral load monitoring with month-to-month dispensing to make sure that the system works effectively. So we understand that currently there has been also an emphasis in multi-month dispensing, and without close monitoring, it might also have a challenge where clients can miss viral load uptake and testing during their milestones. For high burden facilities, particularly district hospitals, we also noted that there is need for additional HR support. In this case, adding more data clerks to support viral load data entry. Next slide. So this is basically what we wanted to share from Partners in Hope as regards to initiatives to support viral load, increased viral load uptake in Malawi, but also the experiences that we have gone through that we felt we needed to share with others. Thanks for your time and thanks for listening. I then hand it over to Jason. Thank you.
Thank you, Mackenzie, for that. For those that have any questions, I didn't see any come into the chat. Well, actually, I just did. For those that would like to speak, please do raise your hand and we'll hand it over. But maybe I could ask Daniel to answer his questions directly to Mackenzie. If you raise your hand, you can speak directly and answer your question. Or I can read. Maybe it's easier if I just read. So this question, go ahead, Daniel. Are you able to speak?
I believe that participants, it's difficult for us to unmute and mute participants.
Okay.
So we might want to save that for later, Jason, too. If we want to go through the presentations, and then we can do that.
Okay, I'll ask Mackenzie the question. So first of all, I mean, thank you for the presentation. Obviously, you know, staffing complement and level of effort at clinical level to achieve some of the challenges or address some of the challenges that were identified earlier. But, you know, there are obviously some coordination efforts and challenges that you described, particularly on the lab front. Maybe we can get into those following Daniel's questions. But Daniel's questions is, how do you keep the data clerks motivated? Do they receive a pay or some sort of stipend? And then who also fits the bill for that? Yes. And are these fully kind of integrated into the Ministry of Health staffing complement, or are they seconded directly by an IP, particularly Partners in Health? So it's kind of a double question here on data clerks. So funding to support them and integration within the Ministry of Health structure. Mackenzie?
No, thanks, Jason, and thanks for the questions. So the data clerks basically are full-time employees of Partners in Hope, as I earlier indicated that these were recruited and deployed by Partners in Hope as an implementing partner to support overall data quality improvement, management, and reporting. So they don't receive additional stipend. They are under the conditions of recruitment by an organization. So no additional stipend that is provided apart from the HR conditions that are provided as part of their recruitment. So they are full-time Partners in Hope staff based at the facility. There was a question about initially who was doing the flagging. So initially when viral load was rolled out in Malawi, it was basically the providers who were assessing the clients and sending them for viral load testing during their milestone. But the challenge that is there, as I highlighted, is we experience a shortage of trained providers with the high burden of clients that they have to take care of. So because of that, most of the milestones were being missed by the providers. And this is why we felt that there was an opportunity with the data clerks being available to support flagging. The beauty is that currently viral load testing in Malawi is not subject to adherence as it was previously the case. So once you hit your milestone, then you have to have your viral load taken. So we felt that was an opportunity that it didn't require further scrutiny in terms of adherence and all other clinical aspects. And we felt it was something that data clerks could easily flag, because milestones, checking for milestones was quite an easy task for them to do. So the other question is about whether these are the focal person at the facilities are secondary staff. So as I said, we have basically 3 lay cadre staff that are available at the facilities. We have the data clerks who are fully employed by Partners in Hope, supporting Ministry of Health. We have the HIV diagnostic assistants fully employed by Partners in Hope, also supporting Ministry of Health. And we have the patient supporters. So all these are fully employed staff by Partners in Hope. And the focal person is amongst those staff, one of the lay cadres, and in most cases is the HIV diagnostic assistant, who is the focal person to make sure that clients are being taken their viral load. At the end of the day, they can sit down, triangulate data in the logbook, viral load logbook, versus what the data clerk had captured as being clients that were due for viral load. So this happened on daily basis at facility level amongst the lay cadre staff. Over to you, Jason.
Great. Well, thank you for that. In the interest of time, I think we're going to move on to our next presentation that will be presented by Mosa Malapa Lasau. And she will speak to efforts in the highlands of Lesotho under the Bela Ethics Project. Mosa is the project director, and she's been there she got 13 years experience in managing HIV-related projects under the Bela College of Medicine's Children Foundation in Lesotho. So Dr. Mosa, over to you. Thank you.
Thank you, Jason. Good afternoon and good morning, everyone. Next slide, please. So as Jason mentioned, I'm representing Bela College of Medicine, Children's Foundation in Lesotho. And just a brief background on our country. It's a small landlocked country in sub-Saharan Africa, and we are totally surrounded by South Africa. Per UNAIDS estimates, this year, estimated population is just over 2,100,000. And per our HIV data, we are amongst the most affected countries in the world, with a prevalence of 25%, and we've been around 25% for a while now. Prevalence among adults aged 15 to 59 years. So that's roughly over 300,000 adults estimated to be living with HIV. And in terms of our pediatric population, the prevalence is around 2% among children less than 15 years of age. The prevalence, especially for children, has changed over the years, with estimates being lower than in previous years, where it was estimated that previously around 20,000 children were living with HIV. So just to give a brief background on our some of our achievements as a country. So we have just recently been given results per the leaf year. So the year revealed that we were one of the first countries to reach the UNAIDS 90-90-90 targets, as we exceeded the second. We met the first at 90, but we also exceeded the second and third targets, so 90, 97, and 92. Next slide, please. So as a country, we are said to have reached epidemic control based on these results. So just a brief background. Baylor College of Medicine Children's Foundation Lesotho is registered in the country as a local organization, and we were among the first organizations locally to implement USAID programs directly. In 2019, we were fortunately awarded 2 big awards. The biggest one is the Karabo ya Bophelo program, which is OBC and DREAMS, offering OBC and DREAMS services in the country. And then we have, for this discussion, the Expanding TB and HIV Clinical Services, or Ethics project. It's a USAID funded fixed amount award. And as I said, we are the prime recipient for this one. We have one sub-recipient, the Lesotho Network of AIDS Services Organizations that helps with tracking of clients who interrupt treatment, etc. So the program started in November 2019, so just after the beginning of FY20. It's a 3-year project, and we took over from ECPAF in 22 of the 10 districts in Lesotho. So we are in the 2 highland districts of Botabote and Mogotlong, and we support a total of 26 sites. Of those 26, 24 are in the 2 districts, whilst the other 2 at the Baylor College of Medicine Children's Foundation Lesotho facilities, one in the city of Maseru and the other in the southern district of Mohale's-Hoek. Next slide, please. So in terms of viral load monitoring as a country, we have been performing viral load monitoring per the WHO recommendation. Initially, this was quite difficult because of lack of resources, including equipment. However, over the years, there has been improvement in viral load monitoring, and now it's universal in the country. And initially, we were doing routine viral load monitoring for PMTCT clients, pediatric clients. However, now all the adult and pediatric populations do receive viral load monitoring. And at the moment, we're also currently reviewing ART guidelines, and the most recent viral load monitoring per WHO is going to be adopted in the guidelines. So as we are aware, viral load monitoring is crucial in ensuring appropriate clinical decision-making for people living with HIV. And it's key in identifying those who may be at risk of poor clinical outcomes. So as a program, Baylor Lesotho has employed several strategies in the supported Highlands district of Lesotho, as mentioned, but also at the Baylor site specifically. And the strategies that we have been employing include side-by-side instruction on phlebotomy, especially in young ones, as this is usually a challenge for clinicians, especially nurses, to draw blood from the young ones. Flagging of files for those who have missed their viral load monitoring is another important strategy that has been ongoing. We also perform viral load monitoring on days that are not allocated as days on which samples can be transported to the labs through utilization of dry blood spot or DBS. In addition, we have been supporting adherence counseling at all the facilities that we support. Next slide, please. At all the facilities that we support for those with unsuppressed viral load and adherence concerns, and this is done through special viremic clinics. And we have also carried out viral load monitoring surges, and there are cases in which we have had to even go out into the community, carry out home visits to ensure that those who miss their viral load monitoring are also given the opportunity. So in addition to utilization of the laboratories, which are offering viral load monitoring, most recently point of care viral load has been implemented across the country, but specifically in the districts that we support. We have currently viral load monitoring being done, POC viral load monitoring being implemented for PMTCT clients, infants, and children, and expansion is in the pipeline. There were some challenges, like most things, as a result of COVID-19 in the expansion, but this is something that's in the pipeline. Next slide, please. So we have also ensured with collaboration from we refer to them as records assistants, but the equivalent of data clerks, collaboration from the records assistants and clinicians. There's improved documentation of patients' results, and there's also immediate identification of identification and management of treatment failure. So enhanced adherence counseling is provided accordingly, and also switched to more potent regimens. And we are also part of decentralized ART advisory committees in the supported districts, but also at national level. Baylor College of Medicine Children's Foundation Lesotho is represented. We have, as a country, ensured rollout of ART optimization with lopinavir, ritonavir pellets, and most recently granules being offered to young children, especially those who were previously on NNRTIs and lopinavir, ritonavir syrup formulation. But also dolutegravir has been rolled out throughout the country, including at the supported sites that I've mentioned. And it's currently for all older children weighing 20 kilos and above, but also adolescents and adults. And currently, we are around 99.9% of ART optimization across all age groups in country. And this has been in collaboration with the Ministry of Health and other implementing partners. Next slide, please. Just a snapshot of our results. So as I mentioned, we started in November 2019, and we took over when at that time the overall viral load coverage was at 83%, with viral load suppression at 91%. But when we closed the third quarter of FY21, we noted great improvements, and this is all due to the hard work that's being done by us, teams at site level, at district level, and also with support from the central level team. So our coverage, viral load coverage, was 92%, and viral load suppression at 98%. And we're glad to say that as of APR, when we close the final quarter of FY21, at the end of September, our results are at viral load coverage of 93%. Across the facilities that are supported under the ethics program, and with viral load suppression at 99%. And this is also in line with what we have seen as a country through the exceeding of the 90 UN/AIDS targets. Next slide, please. And just again, just to give a snapshot of results per age group, we have also noted improvement across the age groups also. At Q3 of FY21, for pediatric clients, the viral load coverage was at 75%, and this was due to some clients not, at one client not having had monitoring performed due to a DBS that had not been, the sample had not been assessed as yet, but as of Q4 at APR, our viral load coverage in the young ones, less than 1, was actually 100%, and we have seen improved coverage with not only coverage, but also viral load suppression across all age groups, with our pediatric viral load suppression rate averaging 96%. Next slide, please. So in conclusion, in the highland districts of Lesotho, as mentioned, a combination of strategies have been effective in optimizing viral load coverage and suppression, not only in the young ones, but also across the older age groups, adolescents and adults too. And this have included enhanced adherence counseling, treatment support, utilization of optimized regimens. As mentioned, we are at over 99%, almost 100% ART optimization with our clients on lopinavir, ritonavir, or dolutegravir regimens, based regimens. And currently we are reviewing the guidelines and with the hope that as pediatric dolutegravir becomes available in the country, starting in the second semester of the next year, we will see almost all our population being on DTG-based regimen. So these are strategies that we hope that we will continue to ensure sustained gains in ensuring epidemic control in Lesotho. Thank you, Jason. That's all, over to you.
Thank you, Mosa. Great presentation. I'm going to pitch it to the audience to see if there's any questions. If not, I think I'll pose a few questions to you. So let's give folks a few minutes with some comments or questions in the chat. I'll wait a few seconds. Obviously, when you're a country that's already achieved epidemic control, any additional kind of gains can be very, very difficult. So it's very impressive even to see small bumps in coverage and suppression. So we all know the closer you get to the 95, 95, 95, the gains become very, very difficult to achieve once you're reaching that high level. So I don't see any immediate questions, but I'm going to pose you one. There was an aspect of point of care that was included in your presentation. I was just wondering what kind of contribution did point of care provide as part of the bumps in coverage numbers, particularly as it relates to pediatrics, recognizing that there are a lot of countries right now that are looking at point of care as a complement to conventional testing. Dr. Mosa?
Thank you very much, Jason.
Yep.
So as I mentioned, point of care is available and being rolled out. However, at the moment, I can't really give the specific proportions of viral load monitoring done through contributed by point of care, but specifically for pregnant and breastfeeding women. And based on the current guidelines where we perform baseline viral load for that specific group, and also 3 monthly viral load monitoring, 100% of our facilities that provide care for pregnant and breastfeeding women are currently utilizing point of care.
Thank you. I do see a question from Vivian Chitoyo. Thank you for the presentation. We'll just take this one question quickly and then we'll jump to the next presentation. Due to the high suppression levels, how do you accelerate switches? Do you conduct resistance testing before switching? I could probably answer that, but I'm going to hand that over to Mosa.
Thank you. So thank you very much, Vivian. In terms of accelerating switches, so as I mentioned, we have at national level, the ART, national ART advisory committees, but as a country, we also decentralized ART advisory committees so that there's no delay in ensuring switches to optimized regimens. However, in the past 2 years, we have also accelerated optimization, ensuring that NNRTIs are no longer being given to patients. And I mentioned that currently we're at 99.9% of our clients on either DTG or lopinavir-ritonavir based regimens, but also for specifically resistance testing for those on PIs, now starting with DTG recently, although we know that it may take a while to see mutations due to DTG, but lopinavir-ritonavir, we've had resistance testing performed, and this is through funding from donors, but not as a country. We don't have national resistance monitoring testing as a country, but IPs sometimes do foot the bill where appropriate for that. But it's included in our guidelines. Thank you.
Thank you for that. That's, I think, going to be a hot question moving forward in regards to resistance testing. I know it's a really hot topic, particularly with some of the integrates. So thank you for that. Let me hand it over to Shalom Dunga, who will speak to some surge-related activities in Malawi. I mentioned earlier that Shalom is a medical doctor specializing in global health, and she works at Baylor, as with Mackenzie, under the core project, though, and she's the district lead for that project in Ngochi. So let me hand it over to Shalom. Thank you.
Thank you so much, Jason, for the introduction, and thank you to the USAID OHA for organizing these meetings, but also the opportunity to present. I'll be sharing our work from Baylor, Malawi on optimizing viral load coverage through activities. Next slide. We have nothing to disclose. Next slide. So to give a brief background to Baylor, Malawi, Baylor Children's Foundation Malawi has been a leader in pediatric and adolescent HIV, but also family HIV care since 2006. We started when we opened the Center of Excellence, which is the largest outpatient ART clinic in Malawi. Since then, Baylor's programs have expanded to include a lot of other services as listed in the slide. And currently, Baylor Children's Foundation Malawi supports over 200,000 persons living with HIV through the USAID funded Tingati Core program. And of those 200,000 people living with HIV, 30,000 are children and the youth. Next slide, please. So a brief background to the core project. Baylor Malawi's Tingati program is the one that is implementing the core project. And we work collaboratively with the Ministry of Health, but also with other implementing partners to support 95 health facilities across 6 districts, and with an aim of helping families to live healthy, fulfilled lives. So Baylor Tingati implements through development and implementation of innovative programming, building local capacity, building sustainable health systems, and delivering direct high quality care to our clients. Next slide, please. Now coming to viral load. As mentioned before by the 2 previous presenters, we know that viral load monitoring is critical to the care of persons living with HIV, both for decisions that affect the clients themselves, but also to make sure that they are suppressed so that we reduce transmission levels to the families. In Malawi, routine viral load is collected every 6 months. Starting at 6 months, not every 6 months, starting at 6 months from the initial ART initiation, and then every year afterwards. There were some policy changes that took place around COVID-19. When we had the peaks of COVID-19, there were always policy changes to restrict movement, but also to decongest health facilities. So some of the changes that took place were around viral load monitoring. And in 2020, during the second wave of COVID-19, viral load collection was limited to pregnant women, children under 15, and clients who had initially had a routine high viral load. At the end of that COVID wave in October 2019, when the restrictions started being lifted, Baylor Malawi implemented a viral load testing surge so that we could catch up all of the clients that had been missed. So the surge activity was an intensive and rapid scale-up of strategies to increase viral load collection among eligible clients. Next slide. So the surge was implemented from the 5th of October to the 19th of December in 2020. We implemented across 30 of the 95 health facilities. These were the highest volume facilities, contributing about 70% of the whole cohort that we take care of. Baylor Malawi Tingate program supports all of these health facilities with site-based staff, including healthcare workers, community health workers, counselors, but also clinical mentors. Some of the clinical mentors are site-based, providing direct clinical care. The other clinical mentors travel to the sites to provide direct clinical care, but also side-by-side mentorship to the Ministry of Health providers. Next slide. So some of the strategies that we employed during the search include during the, before the clinic, we did a MasterCard review to see who is eligible for viral load, and we flagged all the MasterCards of clients who were eligible. We also used the Google platform, Google Forms, to check if all of our facilities were implementing the best practices that as Baylor we promote. And if we noted any implementation gaps, we made sure that we attended to them immediately. Next slide. On the day of the clinic, we rescreened the health passport books on arrival of the clients, so that any clients who had been missed during pre-screening for any reason, or maybe they came to the clinic on a day that was not their clinic day, could be also found. And we redesigned client flow to make sure that viral load collection is done before clinical reviews, because as was mentioned by another presenter before, if clients receive their medicine, usually they don't wait for other services. So we made sure viral load collection gets done before they received their medicine. We also ensured there was enough HR to both do screening and collect viral load samples. And in some cases, we started the clinic early in the morning, as early as 6, so that we could utilize the waiting time to collect viral load samples. Next slide. And finally, there was ongoing supervision for all of the sites. So every day, the facilities had to report through a WhatsApp platform how many clients had come to clinic and how many viral load samples they had collected. Through experience, we have learned that about 40% of clients coming to the clinic are eligible to get a viral load draw. And so any numbers falling below that made us aware that something could be wrong, and we followed up with the facilities. We also sent voice notes and WhatsApp notes to make sure that everyone has a standardized messaging of who should get a viral load, because with changing guidance with COVID, sometimes people got confused. So to make sure that everyone was on the same page, we used voice notes and WhatsApp notes. Next slide. So these are our results. We're sharing in this graph results for a 22-week period. The dotted line there is showing when we started implementing the surge. So 11 weeks before the dotted line were before we implemented the surge, and 11 weeks afterwards were after we implemented the surge. In the whole of that period, we collected over 47,000 viral load samples. And as you can see, the great majority of those samples, 71%, were collected during the surge. We learned that the surge had an immediate effect it raised the numbers of viral load samples being collected every week by about 1,200, and this result is statistically significant. We also learned that the search was able to give a sustained effect. So post-intervention, the trend continued to be that of increasing. So we had additional 50 samples on top of the 1,200, about 50 samples more viral load samples being collected each week post the search. Next slide. Next slide. So that was our main result. And so what have we learned from the search activity? Well, we learned that pre-clinic planning, clinic day adaptations with virtual and in-person supervision can really accelerate viral load testing coverage, thus providing this crucial service to our persons living with HIV. We also learned that collaboration with the lab and the transport partners is very essential. So during this time, as you can imagine, the labs were overwhelmed with COVID-19 testing, but also all of our increased viral load sample collection did really increase demand on the laboratory. So as Baylor, Malawi, we provided HR support to the laboratories to improve efficiencies. We have noted other things as well, like shortages with reagents, sometimes shortages of paper to print results, sometimes ink, also transport delays. All of these, we've learned that they impact the turnaround time. And as Baylor, we have learned to collaborate a lot more with all of the transport partners, the lab partners, and also monitor closely how all of our samples are moving from facility to the testing lab and results getting back to the sites. Next slide. So we did not stop there. We rolled out the viral load optimization to now the rest of the 95 health facilities that were not included in the initial search. And currently, as Baylor Chingate, our viral load coverage, which means that a test was, a sample was taken and the result returned, is at 85%. And our viral load collection among children living with HIV is on average at 99%, with an average viral load suppression of over 93%. Next slide. Thank you so much. That was all that I had to share with you from Baylor, Malawi.
Thank you, Dr. Shalom. Unfortunately, we're out of time. We've kind of gone over a little bit. I'd request people, if they have any direct questions they'd like to direct to Dr. Shalom, please do so via email. Apologies for that on the time management aspect. Just a quick comment in closing. I think all of these presentations demonstrated clear kind of operational shifts in addressing some of the coverage and suppression related issues in each one of the countries. I'd like to thank Mackenzie, Mosa, and Shalom personally for taking the time to participate and to share their programs and what they had done to achieve gains on the coverage related issues that were identified as part of their presentations. So with that, I think we're going to have to wrap up. I know that we got a few extra minutes. We don't have any interpreters, but thank you all for attending, and thank you again to Mackenzie, Mosa, and Shalom for your great presentations. Very much appreciated. Thank you all.